Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today my lesson includes a brief talk on aortic regurgitation. Aortic regurgitation is the volume overload under the left ventricle because of the incomplete closure of the aortic valve during diastole, resulting in backward flow of the blood into the left ventricle. So this volume of blood is added to the diastolic filling of the left ventricle from the left atrium. So this regurgitation is either due to the defect in the native valve or caused by the acquired diseases. The prevalence of the aortic regurgitation in the United States is around 4.5 to 10%. It's more common in males than in females. And this topic we are going to touch in terms of pathophysiology, its clinical presentation, and treatment. This is the areas of aortic regurgitation which we are going to touch briefly in this lesson. So valvular anatomy, either bicuspid or otherwise, etiology, pathophysiology, and clinical features with the natural history and the diagnosis, and laboratory evaluation and the steps of management. So aortic regurgitation and its causes. It could be valvular or root causes. The valvular, it could be congenital bicuspid valve, rheumatic fever, which usually causes aortic stenosis. It can also result in aortic regurgitation. Bacterial endocarditis, which results in the damage to the aortic cusps, resulting in aortic regurgitation. Myxomatous degeneration followed by prolapse, syphilitic aortitis, or traumatic. Diseases of the aortic root, aortic dissection, aortitis of any cause, bicuspid valve, again results in aortic regurgitation, cystic medial degeneration, and Marfan syndrome and hypertension. Again, to touch some more aspects, that is calcified aortic valve is again a cause of aortic regurgitation. Aortic valve rupture with leaflet prolapse is one of the causes of aortic regurgitation of valvular defect. Then VSD with aortic valve prolapse. Some collagen disorders like systemic lupus erythematosus, syphilitic aortitis again results in aortic regurgitation. Aortic root defects, age-related degenerative changes at the root of the aorta can result in aortic regurgitation. Marfans and Behcets are rare causes of aortic regurgitation. Another one is systemic lupus erythematosus and aortic dissection with retrograde flow, chronic inflammatory diseases like ulcerative colitis, then chronic severe hypertension are some of the causes of aortic regurgitation involving the defect in the aortic root. Then what happens in a aortic regurgitation? What are the abnormal hemodynamics? As I told you, there is volume overloading of the left ventricle. Initially, there is good compliance of the left ventricle. Well, accepting the volume of the blood that flows backwards from the aorta into the left ventricle, and also the regular volume of blood that comes from the left atrium into the left ventricle. So this volume overload is well accepted by the left ventricle with good compliance. That resulting in the increase in the left ventricular and diastolic volume without without raising the end diastolic pressure. Okay, and left ventricle responds to this increase the left ventricular end diastolic volume by chamber dilatation and eccentric hypertrophy. Okay, that results in the increased stroke volume, which is equal to the volume of the regurgitated blood plus regular ejection volume. The sum of the regular ejection fraction and the added regurgitated volume results in the increased stroke volume. This results in the rise in the systolic pressure and increase in the afterload. Okay, so this compensatory mechanism continues for a long time before the onset of symptoms. That means the latent period of aortic regurgitation before the onset of the symptoms is long. It may be as long as few decades. Once the symptoms set in, there is deterioration is rapid. Well, to repeat, aortic regurgitation is associated with volume overloading of the left ventricle. Increase in end diastolic volume results in the dilatation and eccentric hypertrophy of the left ventricle. So it allows the ejection of large stroke volume. What is that large stroke volume? It's the result of sum of the functional stroke volume and regurgitated volume. Okay, that causes rise in the systolic pressure. When the large stroke volume is pumped into the circulation, so there is rise in the systolic pressure. That results in the increase in the afterload. Results in the increasing afterload compensated by the hypertrophy of the left ventricle and compliance of the ventricles without causing the impedance to inflow. That is, good compliance of the ventricles is maintained for a long time without causing the impedance to the inflow of blood from the left atrium into the left ventricle. So this compensatory mechanism will continue for a long time. But so in course of time, there is increasing end diastolic volume, reduced compliance, and that results in the fall in ejection fraction and reduced cardiac output and increasing end diastolic pressure. So rising end diastolic pressure in the left ventricle is secondary to the poor compliance of the left ventricle that leads to the elevated left atrial pressure, pulmonary venous pressure, symptoms of left heart failure. Okay. So this is the point of onset of the symptomatology. After a long compensatory period, the left ventricle refuses to comply with the inflow of blood, either due to regurgitation or due to the flow of blood from the left atrium into the left ventricle. So this results in the raising end diastolic pressure in the left ventricle that is transmitted to the left atrium, thereby causing the pulmonary venous congestion and pulmonary edema and symptoms of left heart failure. Okay, that results in the increase in the pulmonary wedge pressure and right ventricular failure. So over time, there is increased oxygen demand due to increased left ventricular wall thickness. Okay, so that is not met by the coronary filling of the coronary filling during diastole, that which results in the exertional angina. Chest pain during sleep occurs due to fall in the coronary filling. Over time, there is myocardial dysfunction and heart failure. This is the course of events that occur in the patient with the aortic regurgitation, resulting in the congestive heart failure. That what happens in the chronic aortic regurgitation. Coming to acute aortic regurgitation, usually caused by bacterial endocarditis, aortic dissection, or blunt chest trauma. Sudden large regurgitant volume imposes on the left ventricle of normal size that has not had time to accommodate the volume overload. Okay, left ventricle has not prepared, not in a position to receive the large regurgitant volume. So there is abrupt increase in the left ventricular and diastolic volume, which leads to rapid and dramatic increase in the left ventricular and diastolic pressure and, and left atrial pressures. So inability of the ventricle to develop compensatory chamber dilatation results in a decrease in the forward stroke volume. Okay, that results in tachycardia as a compensatory mechanism to maintain the cardiac output, but often it is insufficient. Okay, this is a sort of medical emergency. That means there is sudden overloading of the left ventricle which is not prepared to handle the end-diastolic volume, which results in the dramatic rise in the left end-diastolic pressure, then the left atrial pressure, which is transmitted to the lungs, pulmonary backward pressure into the pulmonary veins, and this dramatic fall in the stroke volume, resulting in the cardiogenic shock. This is what is already mentioned. Acute aortic regurgitation. Rapid increase in the end-diastolic volume of left ventricle, and compensatory mechanisms do not develop that rapidly to handle the extra load. That ends in the pulmonary edema, acute left ventricular failure, and cardiogenic shock. So, left ventricular and diastolic volumes increases so rapidly that may result in diastolic mitral regurgitation. You see, the end diastolic pressure in the left ventricle is so much that results in the diastolic regurgitation of the blood into the left atrium. That is diastolic mitral regurgitation. So most of the blood is regurgitated into the left atrium even during the left ventricular diastole, and the forward flow into the systemic circulation is dramatically reduced, resulting in cardiogenic shock and death in acute aortic regurgitation. Coming to the symptoms of chronic aortic regurgitation. The symptoms occurs after a long time after the onset of aortic regurgitation in chronic entity. Okay, so there is onset of the exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and there is palpitation because of the volume overloading of the left ventricle. There is angina pectoris, chest pain. There is nocturnal angina due to slowing of the heart rate and fall in diastolic pressure. Okay, that results in critical fall in coronary filling. It is during the diastolic and the coronary filling takes place when there is diastolic pressure drops in the root of the aorta. Coronary filling falls low to the very low level, resulting in angina. Coming to the signs, collapsing pulse or water hammer pulse, wide pulse pressure, first heart sound is normal, second heart sound is diminished in intensity or loud. You can appreciate systolic murmur in the left upper sternal border radiating to the carotids because there is a rapid flow of blood into the aorta due to the increased stroke volume that results in the turbulence in the aortic root, okay, during systole. That results in the systolic murmur appreciated in the upper left sternal border radiating to the carotids. Then there is early diastolic decrease in the murmur at left third space. Okay, there could be hollow diastolic murmur in severe aortic regurgitation. Okay, coming to the peripheral signs of aortic regurgitation. There are so many signs have been described in various names. The specificity and sensitivity of these clinical signs are very much variable. They have got poor specificity and sensitivity. Remember this point. Austin Flint murmur is mid-diastolic murmur at mitral area because regurgitated jet falls under the anterior leaflet of the mitral valve that causes the narrowing of the mitral orifice during diastole. That results in the mid-diastolic murmur. Becker's sign. It is visible pulsation in the retina. Bispherians pulse. It is biphasic pulse that is seen in the aortic regurgitation. Corrigan's sign. It is water hammer pulse. Demoset's sign. Head bobbing with each pulsation. Duroger's sign. That means there is systolic murmur appreciated under the over the femorals proximal to the compression and diastolic murmur distal to the compression of the femoral artery. Gerhardt's sign, pulsation in the spleen when there is splenomegaly. Hill's sign, blood pressure is the lower extremities higher than the upper extremities. Main sign, fall in diastolic pressure more than 15 mmHg when the arm is elevated. Muller's sign, systolic pulsation of uvula. Quincke's sign, capillary pulsation at the base of the nail bed. Rosenbach's sign, pulsations of liver. Troby's sign, pistol short systolic and diastolic sounds on the femoral artery. Pistol short systolic as well as diastolic sounds on femoral artery. So these are the peripheral signs called after the name of so many names that are being mentioned here and whose specificity and sensitivity is very poor. Okay. Then Having understood the pathophysiology and the clinical manifestations, how do you go about the treatment? Acute aortic regurgitation, it is a medical emergency. So treat the condition with afterload reducing agents like infusion of sodium nitroprusside and give the inotropics to improve the stroke volume. After stabilization, go for surgery with aortic wall replacement. Chronic aortic regurgitation is treated by medical management to stabilize the condition, followed by which you can take time for the surgical intervention, and the best option is the aortic valve replacement surgery. Okay, these are certain of the diagrams showing the auscultatory findings in aortic regurgitation, aortic stenosis. This is the ejection systolic murmur. This is the early diastolic murmur, and the diastolic murmur continuing into the starting from the second heart sound, going close to the first heart sound in severe aortic regurgitation. Well, look at this echocardiogram. It's a case of aortic regurgitation. A regurgitant jet impinging on the anterior leaflets of the mitral valve. Here you see the causing impedance to the flow of blood from the left atrium into the left ventricle during diastole. That results in the presence of mid-diastolic murmur at the mitral area. This is called Austin-Flint murmur. This aorta, well, there is a regurgitant jet into the left ventricle from the aorta. Okay, regurgitant jet. This is the pulse wave, Bispherians pulse with two waves here. Water hammer pulse. Right. This is the X-ray chest showing you the cardiomegaly and dilatation of the left ventricle. Well, to sum up, aortic regurgitation is the retrograde flow of the blood from the aorta into the left ventricle due to incomplete closure of the aortic valve leaflets. This results in the volume overloading of the left ventricle, initially compensated by the left ventricular dilatation and the eccentric hypertrophy, and maintaining the compliance without raising the end diastolic pressure. So over time there is increasing end diastolic volume with increasing end diastolic pressure, which is transmitted into the left atrium, from there into the pulmonary venous circulation into the right ventricle, ultimately resulting in the congestive heart failure. Okay. The initial compensation results in the increasing stroke volume and increasing afterload. Over time, in chronic aortic regurgitation, it takes long time to the onset of symptoms. Once symptoms appears, there is a downhill course of the disease resulting in congestive heart failure and the morbidity. The acute aortic regurgitation, which is a clinical emergency, unless otherwise treated early, there could be cardiogenic shock and death. Well, thank you for patient listening, and we'll meet you again in the next class. Until that time, bye bye. See you.